We're not going to have question and answer now. We're going to have that at the end before coffee, including questions on our next subject, which is the subject of cancer networks. So up to now this morning, we've focused on individual cancer centers. Now we're going to look at the importance of networking. And I'm afraid if I need to bore you with the sound of my voice for another probably 10 minutes on, first of all, just to explain the challenges, or share the challenges really that there are with networking in cancer, and then to have two very good examples of networks of different kinds within our OECI program. So moving straight on. So this is the challenge, isn't it? How do we reach, or how does the infrastructure, the system, reach all cancer patients in a region or in a nation with quality assured services? Because not all centers do a great deal of research, whether translational or clinical. How can that innovation be disseminated to all centers and for all patients? How can clinical trials be equally accessible across a locality or a sub-region to all cancer patients? What is the pathway for patients who need complex treatments to be, for their care to be transferred to centers of reference or other hospitals? Data sharing is a huge challenge within that whole trajectory. And of course, the answer to some of these challenges is effective cancer networks. Now, we published, I think about 18 months ago now, a study on the evaluation of comprehensive cancer networks. And we looked actually in a literature search around the world about the best means of evaluating the effectiveness and the quality of health networks. We looked not just at cancer networks, but health networks throughout the world. And what standards would be appropriate to measure and to evaluate the quality of a network. We identified more than 1,000 articles. There are only 17 of those, actually. The literature is pretty thin, to be honest, to have evaluation methods with quality indicators for networks. And we had already drawn up our own putative list of 54 proposed standards on networks. And most of those, 32 of them, had a literature equivalent. And of course, the evaluation methods, there's nothing rocket sciencey about this, were questionnaires, surveys, document review, and a physical site visit again, as with a cancer center peer review. And from that, we deduced 8 principles for evaluating the effectiveness of cancer networks. And these are the 8 principles we adduced. First of all, the network should have a defined governance structure. Now, we're not talking here, and perhaps I should mention this now, we're not talking predominantly here about a big research network, like the Alleanza contro il Cancro in Italy, for instance. We're not talking about that, we're talking about a locally based care network. I've got a slide on this in a moment, which involves perhaps general hospitals, and certainly university hospitals and a cancer center. That network should have a defined governance structure with clear objectives. That the network, number 2, should have broad representation of key stakeholders right away across the continuum of care, optimally actually also including a link with primary care, although that's often difficult to achieve, of course. To ensure full multidisciplinarity throughout the patient pathway. To ensure patient-centeredness throughout the cancer journey, and to be involving patient representatives within the network board. To ensure a focus, number 5, on sharing best practices and promoting innovation. And number 6, to promote uniform quality standards across the network. Now, of course, if you're dealing, as we're about to hear one in the Netherlands, with a network of 9 or 10 different hospitals, they will have their own governance structures. They will have their own reporting structures and their own quality indicators. But how how can you bring those together in a comprehensive way so that they can be compared and so that features and indicators, including outcomes of patients, can be compared across those different hospitals in the network? Number 7, that there are instruments, which it follows on, doesn't it, for monitoring and continuous improvement, not only of care quality, but also research quality as well. And finally, of course, the hospitals within the network, they don't all necessarily need to have the same IT system, and there are very few countries in the world or regions where that is the case. All the hospitals will have a different IT system. The question is, are those systems interoperable, and can the data of cancer patients be easily, very quickly and accurately transferred from one hospital to another where there is a transfer or shared care? So those were our 8 principles that we adduced. This is a different way of representing it. But OECI has other principles that we like. Oh, suddenly got some extra lighting. That's good. Will wake us all up, won't it? Our principle is that we want the center, the hub of a network, to be either a comprehensive cancer center or a large clinical center to be present, which acts as not as big brother, as we shall see from examples in a moment, but actually which coordinates, which certainly, if it is the hub for research, makes sure that research, and clinical research in particular, is accessible across the network. And that strategic research collaborations, therefore, should be clear and promoted, and that there should be a consistent approach to registering the data of cancer patients. Sorry, I've gone backwards. Let's go forwards. So that was that's the classic schema of a comprehensive cancer network. It was also a schema that was shared with the European Joint Action IPAC, in which OECI was involved, that a classic comprehensive cancer network should have at least, as I say, one CCC or large clinical center. There'll be research institutes, there will be parts of general hospitals, and there may be private or public diagnostic units as well. And that they cover the whole patient pathway, right from prevention, diagnosis, and treatment through to palliative care, rehabilitation, and also including research. These are the domains you're very familiar with of our center standards. So I'm not going to go into those in any great detail. But when we're evaluating networks, I'm not going to show you all of the standards, but they are available on our website. We're looking at the horizontal connections, aren't we, between those organizations. So if you like, the review that we do of the center, or one of the centers, or one or more, is a kind of deep dive into the details and the quality of that center. And then the network accreditation is a more horizontal approach, where we're looking at the connectivity and the consistency of the quality approach across the entire network. So here are a couple of examples of our core network standards. Number 32, the network has policies and procedures for ensuring equal access of patients to care throughout the network and reducing variations in outcome. So that's quite a big one. If you're dealing with a network, I think we're about to see one of about 2 million population, then actually ensuring that patients have equal access to high quality treatment and you're reducing variations in outcome is really, really important. Standard number 21, that they use an agreed set of performance indicators. There's always a danger, I think, in cancer and quality indicators of too much data, especially if you're sitting on the board of directors. But actually, what are the real data? What the real marks of quality, whether it be for surgery, and there are some prominent surgeons in the audience here today, or in medical oncology, or in waiting times, or in all sorts of areas of quality and risk. So rather than having 100 quality indicators, what are the 20 absolutely most key for the top management to be monitoring month by month and having consistency across the network of those? Here's another one. This is the basic resources, the standard 15. There is a network coordination team with the resources to coordinate the activities of the network, and actually probably a role in functional data systems as well to enable the network to operate efficiently. There's a role with MDTs. I mean, we've seen structures where big hospitals, of course, they've got their own individual MDTs for their own hospital, but with the rarer cancers, of course, there's a strong, compelling argument for a cross-network MDTs. So how do they work, and how do they work effectively? And finally, enrollment of clinical trials, that a patient in the very rural area of that locality, the most inaccessible, still has the same access to a clinical study as the person who's in the center and can just pop down the road to the university hospital. So we're about to hear about Oberst. So this is just a little flash report. We're about to hear about FICAN here in Finland. Two different types of networks. But a quick shout out to other networks around, to the very effective and growing network in Ireland of 9 designated centers, and 7 out of those have had a full, or are sorry, and in the process of a full review. Some have had them of the OECI, but you know, the effectiveness of that network in terms of minimum treatment volumes, centralization of care, especially of surgery, really, really important. Where I now live, actually, still don't speak the language yet. It's a very difficult language, Danish. A comprehensive cancer network already exists, and has existed for many years. And I shout out to Denmark, because the Danish Comprehensive Cancer Center really, with its constituent hospitals, has made the biggest improvement in cancer outcomes in Europe, possibly in the world, in the last 20 years. I think that's right, Meph, isn't it, in terms of the statistics? It was, in terms of cancer survival, on a par with my old country, the United Kingdom, nearly 15 to 20 years ago, 2/3 of the way down the league table of survival, actually. And in the last 15 to 20 years, Denmark has moved right the way up that survival table by taking a networked approach to cancer care, and also very effective procedures within primary care and the access of quick access of suspected cancer patients into specialist centers. And if you look at, you can read the literature on this, but they've done a remarkable job. So that's a job that, you know, if you come from certain other countries around, you know, around Europe, you know, the Danish principle and the way they've achieved it could be something to be copied. A little shout out to Denmark. We did a survey through the Joint Action on Rare Cancers, which OECI helped to lead, of, you know, what are the nature of cancer care networks around Europe. The ones in the dark blue are ones which have national level cancer networks. The ones in orange with regional level, that's Spain and the Netherlands. And there are some countries that have a mixture of both. And there are a number, I think it's 7 countries probably listed on this next list at the bottom there, who as yet have no cancer networks at all. Our colleagues who we're working with in Latvia, Bulgaria, Romania, Greece, Croatia, Malta, and strangely, Jean-Benoit, Belgium. Although there is a robust and growing Belgian cancer research network, the BCRA, which is about to be strengthened. So a mixed picture across Europe, France, patchy, different kinds of networks working with different effectiveness. Same in Italy. Germany works on a process of outreach more than formal networks. So each of the 26 comprehensive cancer centers in network, in the network of the Deutsche Krebshilfe, are, as part of that grant, given an imprimatur to outreach to other centers, whether private or insured or public, within their system. So that's called network. The Netherlands, as we're about to hear, will achieve full coverage of cancer networks across the country. Also, like my old my old place, England, which was the first to introduce cancer networks in the 1990s, following the Kalman-Heim report. And once they were working successfully, the government abolished them. So, but they left their mark because they had already negotiated the patient pathways across all the 28 cancer networks. So even though the jelly mold was taken away, kind of the jelly of clinical networking remained. We're about to hear from Finland, but a shout out to Sweden as well. The Czech Republic certainly has had some very effective networks, particularly the one around Brno. Poland's are growing. Somebody might like to give information about that in the question and answer. So I think this is a bit of duplication. I'm not going to say much more about that. So finally, the opportunities and challenges of cancer networks. The opportunities, I think, to integrate and accelerate research and innovation throughout a whole care network. Obviously, the balance that there is between optimizing care that is close to home, but balancing that with the challenge and the improvement that we all see and we all know about in the literature from specialist centralization, not just in surgery, also obviously in radiation oncology, but in many of the complex treatments. This question of managing treatment volumes, and there are still some countries in Europe that do not set minimum or advisory minimum treatment volumes. And therefore one finds, and we find this on review, centers that are, in pancreatic surgery are doing very few such surgeries, and we challenge them on that. I think there is a challenge whether OECI should look at the consensus from the European Society of Surgical Oncology and start to actually ourselves either recommend or even impose minimum surgical volumes as a treatment quality proxy, but we haven't yet decided on that. The challenge of deepening multidisciplinarity, the challenge of bringing researchers and clinicians and patients together, and I love the talk from Beaumont about these research groups that are disease-focused and that bring together clinicians and researchers in collaborative programs. That is absolutely the way to go in comprehensive cancer centers and optimizing clinical trials. The challenge is, there's always the challenge, and this is actually true of comprehensive cancer centers, of different funding mechanisms for health and research, and that is common absolutely throughout us in Europe. Cancer networks begin with no centralized funding at all. So how do you make them function? How do you give them some resources to develop, except in countries that have decided to formalize the cancer networks with Ministry of Health support, such as in Ireland, but that's a very unusual case. That is very, very rarely done. I think the Netherlands networks have no Ministry of Health funding at all, Fabrizio, no. So, how do you build and share the resources at a network level? IT interoperability, I can just about say it, is always a challenge for the networks and sharing data. And the final one is expertise traveling. Is that just an ideal? How do second opinions work? Are professionals moving between hospitals rather than the patient, which certainly happens in England and in some networks that I know of. So that's the sort of just general introduction to the challenges and opportunities of cancer networks.